All right, well, why don't we go ahead and begin. The title of this talk is A Simplified Approach to the Spaces of the Head and Neck. But really the intent of my talk is just to really give a more simplified approach to the spaces of the head and neck. And what we'll do over the next 45 minutes or so is cover the various spaces as is seen here. And hopefully, by the end of this 45 minutes, the residents in the audience will understand that the spaces of the head and neck were not created to torture them on the boards. Rather, the spaces of the head and neck were defined years ago, back in the late 1700s, when the French anatomists would try to have some explanation about why infections involving the craniofacial area could eventually kill someone. And the way they killed these people was either through a mediastinitis or extension inferiorly through the diaphragm, leading to abdominal abscesses. So again, this was long before the days of antibiotics. Remember, antibiotics were first discovered by Fleming in the early 1920s. And right now we're in the days of healthcare reform and cost control and cost containment. And when penicillin was first described back in the 1920s, they said it was just too expensive for widespread distribution. And then something happened, obviously, in 1940 that caused a tailwind that made penicillin be widely disseminated. And that was actually, obviously, World War II. So when the veterans came back, it said, well, we need to do something. And that's how penicillin became distributed. And the only reason I know that is I learned from Mary Sue Coleman, who was the president of U of M. It turns out she was a biochemist. And somehow we were having a sidebar conversation one day. So I'm listening to her, and all of a sudden she gets into this. I had no idea she was a biochemist, but there's your history. So the spaces in penicillin certainly are all linked. So we'll go and start with the masticator space. And the masticator space, pure and simply, are the muscles of mastication. In general, the three primary components of the masticator space are the muscles of mastication, which are the masseter muscle, the lateral and medial pterygoids, which I would argue should be renamed the superior and the inferior pterygoids, the temporalis muscle, so we have the four primary muscles. Then we have primarily the bone of the mandible, and as we'll also see in just a jiffy, the third division of the fifth cranial nerve. So here's an anatomic illustration of the masticator space. And if I had to draw this out on this image, I would draw it, something that looks like this. I come here, and then I go around here, and then come back and go all the way through. And this is surrounded by the parotido-masseteric fascia. But in general, that's where the masticator space is on the axial images. So here are the muscles of mastication here. Here's the coronoid process. Here's the condyle of the mandible. And this little bump that I drew here just goes over this oval-shaped structure, which is V3. On the coronal images, we have to look for the muscles of mastication. Here's the temporalis muscle. There's the masseter muscle. And if I had to draw the masticator space, I would end up drawing something like this, coming around the mandible, and then coming up like that. So much more extensive on the coronal images than we initially think on the axial images. So when we look at differential diagnosis for the masticator space, the three primary components are muscle, bone, and nerve. And by using an anatomically based understanding of the components of the masticator space, then we can come up with a differential diagnosis. So here's a large mass involving the masticator space. How do I figure out exactly it's the masticator space? Well, it's pretty sophisticated. What I essentially do is I take my index finger, this finger here, and I place it in the center of the mass, and then I map it to the opposite side. And if my index finger tends to map in the middle of the space on the opposite side, then I know it's in the masticator space. So again, I take a pretty simplistic approach to these things. Now, knowing full well that the largest component of the masticator space is muscle, then don't think about the head and neck, but think about other areas of body like the leg. So if you know the primary component is muscle, if you think of the leg, then you start coming up with a differential diagnosis that we're probably more familiar with and comfortable with as opposed to the head and neck. So we think about rhabdomyomas, rhabdomyosarcomas, leiomyomas, leiomyosarcomas, synovial cell sarcomas, malignant fibrous histioid sarcomas, so on and so forth. So for instance, if I told you, without even looking at the films, that you had a 12-year-old boy that had a rapidly enlarging mass in the masticator space, knowing that the largest component is muscle, what's the number one diagnosis you would think about? Rhabdomyosarcoma, exactly right. So that's how you can use the anatomically based approach to evaluate the masticator space. Another example here, another mass involving the masticator space. In this particular case, it's along the medial aspect of the masticator space. This was a 14-year-old kid, and this happened to be a rhabdomyosarcoma. We can also have these crazy jaw lesions that we're all familiar with. Remember that primary component was muscle, but now we know that the jaw is a component of the masticator space. So what are the things we think about? Well, in this particular case, on your left-hand side, there's an osteoma. On the right-hand side, it's one of those crazy jaw lesions. This one starts with an A. Anybody want to take a guess at that one? Yeah, ameloblastoma. And the other things that it can involve too, again, can occur anywhere else in the body. So if you had an older person like me, I'm heading towards the late middle ages of my life, metastases, you can have myeloma, infections, odontogenic processes, so on and so forth, odontogenic keratosis. So all those bony lesions are included in the masticator space differential diagnosis. And in this particular case, a little bit of an older case, but I like it because you can see that the lateral pterygoid muscle is being displaced laterally, which tells you that this mass has to be just medial to the lateral pterygoid muscle. So if we look at the opposite side, like I said, I stick my index finger, look on the opposite side, I know that pterygoid muscle is being displaced laterally. So wherever this is arising from, it has to be just medial to the medial border of the pterygoid muscle, and there's that oval-shaped structure. And on the coronal images, we can see this mass extending superiorly through foramen ovale. That causes the waist or the dumbbell-shaped appearance, and this is a neurofibroma or potentially a schwannoma. So that's how we can generate a differential diagnosis based on the anatomy. In one other example here, this actually was retrograde perineural spread of tumor along the third division. So from an anatomically based differential diagnosis, three primary components are muscle, bone, and nerve. And if you know those three primary components, you can generate a differential diagnosis. Now, I would submit to you that all of the things I mentioned just now, you've heard of. You may not map it to the head and neck, but if you took that same thing and you put it into the leg or the abdomen, it's probably going to be much easier to come up with that differential diagnosis. Just realize that the components of the head and neck are similar to everywhere else in the body. So therefore, we just have to remember the anatomy and we can come up with that differential diagnosis. So the next space that we'll discuss is the visceral space. Now, the visceral space has a lot of names to it, and as I often say, you know, we head and neck guys, you know, we're pretty clever chaps because we can take the same piece of anatomy and give it different names. So, and we confuse the heck out of you. So one year we'll say this name, the next year you come back, we'll give it a different name, and the third year we'll give it a third name, and you're completely confused. And over time, the names have changed. So for those of you the radiologists in the audience, how many of you in the audience went to medical school? That's about 10%. All right, that's about it. Now, so when we were in medical school and we took our anatomy courses, I think, how many of you remember the fascia of the head and neck? Anybody? Nobody, okay. Well, take what you know and forget it, right? That was very easy, right? So in the fascia of the head and neck, there's a superficial and a deep cervical fascia. And the deep cervical fascia actually has 3 layers to it. Now, the middle layer of the deep cervical fascia is what I'm going to contour here, and you'll see it also on the next slide. But this black line here is the middle layer of the deep cervical fascia. And this has different names to it. So what the term that I use, and I stick to this pretty consistently, is the terminology that we use by the classic articles in the 1930s, primarily by Grudinsky and Holyoke. And they describe this fascia as the visceral fascia. Now, if you look at Amersis or StatDX, they now change that name to the pharyngeal-basilar fascia. So if you read one textbook and you learn it one way, then you read something else and you're like a different name to it, just realize they're the same thing. So I tend to use the historic name assigned to this. So I say that's the visceral fascia. And if you understand that's the visceral fascia, then it gets really simple. So what's a space that's enclosed by the visceral fascia? Take a wild guess, right? It's the visceral space, okay? So everything that's enclosed by the visceral fascia is in the visceral space. So how do you remember the visceral space? Well, it's pretty simple. Just ask someone to open their mouth and look in their mouth. Go ahead, really. You can get to know your neighbor that way, right? There you go. Thanks, Kevin. So if you look in someone's mouth, and actually when anyone performs an endoscopy, anything that the endoscopist sees along the mucosal surface of the pharynx and your oral cavity, and we'll talk about these things later, that's the visceral space. So what do you think the most common tumor to involve the visceral space is? Take a wild guess. Yeah, squamous cell carcinoma, exactly right. So, 1, 2, and 3. Certainly there are other diseases that occur there, but if you just remember the visceral fascia is everything that you see when you perform endoscopy, then it's pretty easier to conceptualize what the visceral space is and also generate a pretty clean differential diagnosis. So now just a little bit more detail, we'll discuss all of these other areas a little bit later, but this black line here is the visceral fascia, and everything enclosed by the visceral fascia is that visceral space. So this is an example of a patient that has a visceral space mass, the most common lesion, the most common tumor, I should say, to involve the nasopharynx. Anybody want to take a gander at what the diagnosis is? We're all friends here. Anybody? Yeah, squamous cell nasopharyngeal carcinoma, exactly right. Very, 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 very simple stuff. Now, this one, on the other hand, we could be here all day, and it'd be really tough to get this. This is another aggressive visceral space mass. It's in the nasopharynx. Number 1, 2, and 3 would be squamous cell carcinoma, but in this case, this is pathologically proven metastatic adenocarcinoma involved in the nasopharynx. So the point of this case is that a lot of the tumors look exactly like each other, and especially when we talk about minor salivary gland tumors and lymphoma, et cetera, there's a lot of crossover in that radiological appearance. But one of the things that I learned during my fellowship 25 years ago, especially in head and neck, is that about 80% of what we see on imaging can either be directly palpated on physical examination or can be seen at endoscopy. So our job is to certainly point out the abnormality, but not necessarily to give a differential diagnosis as we're programmed to do as residents. Rather, what we really want to do is identify various spread patterns of disease. So the point is here is that this looks exactly like squamous cell carcinoma. It certainly could be. But our job is to say that it's in the nasopharynx. There's no extension deep into the parapharyngeal space. And therefore, this is an isolated lesion. And the final pathology is going to be up to biopsy. This is one of the tricky ones that we can see in the visceral space. This was a kid. And this is, again, a 10-year-old kid. And you see something like this, and it's a pretty aggressive abnormality. But anybody want to say what this is? In a kid, benign lesion? Anybody? Yeah, just lymphoid hypertrophy in a kid. And one of the challenges that you get into is you see something like this, it's pretty big, and you also see these guys like right here, which we'll discuss later. These are the retropharyngeal lymph nodes. But the challenge is how do you know it's not squamous cell, a nasopharyngeal carcinoma in a kid? Well, first of all, lymphoid adenoidal hypertrophy is common in a child. So when I see something like this and I look at the prevalence, I'm just thinking that's probably going to be that. But how can you be for sure? That you can't be 100% sure, but certainly if you don't see any extension of this through the visceral fascia into the parapharyngeal space, then we're much more comfortable that this probably just is adenoidal hypertrophy. So in the kids, realize that this is a common disease entity. It can be confusing. And even if you see the enlarged retropharyngeal lymph nodes, again, very, very common to see in children. So this is one of those mimics that we should be aware of. And what about this? Here's I just got back from India 3 days ago, so I'm literally walking in my sleep right now because it's midnight there. I haven't fully converted, but we'd say that this is a spot diagnosis. So anybody want to take a guess at what this is? Torn wall cyst, exactly right. Good, very good. Well, the next space that we'll talk about is the retropharyngeal space. So again, pure and simply from a conceptual standpoint, what do you call the space that's located behind the pharynx? So here's our pharynx here. So the space here that's shown in red, in general, you consider as the retropharyngeal space. So I know a lot of you, you'll hear a lot of head and neck radiology today, and a lot of you do things besides head and neck radiology. So I'm sure there are people here that will do head and neck, then you'll do neuro, you'll go embolize a spleen, read some mammograms, and then read an abdominal CT or something. So there's a tremendous amount of information that you have to be aware of. So in general, if you can remember on Monday that the space behind the pharynx is a retropharyngeal space, that's terrific. But we can take it one step further, because the next fascial layer that's located behind the visceral fascia is this dashed line right here. And this dashed line is a very, very thin fascial layer that's referred to as the alar fascia. So the actual retropharyngeal space is a space that's located between the visceral fascia here and the alar fascia. So if I had to point at it, if I drew my brackets right here, from here to here, that is the true retropharyngeal space. And within the retropharyngeal space are the retropharyngeal lymph nodes. So remember I said earlier, why was the cause that would people try to identify the spaces back in the 1700s? How could an infection involve the craniofacial area extend into the mediastinum? Well, the answer was through the retropharyngeal space, because the retropharyngeal space, this space between the visceral fascia and the alar fascia, terminates in the mediastinum somewhere between T2 and T6. Now, the space here that's located between the alar fascia and this dotted line right here, which is the pre-vertebral fascia, has a different name to it. And this is the one that extends inferiorly all the way through the crura of the diaphragm and is continuous with the retroperitoneal space. And does anybody remember the name of this space? What's that? Danger space. I always remember, anybody used to watch Lost in Space? And no pun intended, but I didn't even make that segue until just now. But does anybody remember the robot that you say, Danger Will Robinson? Every time I hear, you see all you young guys, all the residents of fellows are like, what's this guy talking about? I have no idea. Well, go to Netflix or YouTube or something like that, and then you'll understand what I'm talking about. But every time I hear Danger Space, I always think of Lost in Space with a robot saying, Danger Will Robinson. But you're starting to get a sense of how my contorted mind thinks. But anyway, it's a danger space that's located between the alar fascia and the prevertebral fascia that extends all the way through, down through the mediastinum, through the crura of the diaphragm, and is continuous with the retroperitoneum. So the retropharyngeal space really is a potential space, and there's not that much that lives there. We talked about the lymph nodes that are there, but this is an example of trauma. And this is just a nice example of the air extending through the retropharyngeal space. Now, there has been described a midline raphe in the retropharyngeal space, which is kind of tough to see. But this was just a nice air fasciogram, if you will, demonstrating that midline raphe. This is one of those things that you sometimes see. This was a carotid artery that wandered away from the carotid space. This one extended in the retropharyngeal space. And actually, the reason why we did this CT at the time was that the head and neck surgeon ordered the contrast-enhanced CT because he thought he saw something pulsating, and he wanted to get the CT before he did the tonsillectomy. So in this particular case, we can see the plumpy tonsils here on both sides, but there's a carotid artery that's wandered into the retropharyngeal space. And this is just an example of the retropharyngeal lymph nodes. And just a brief little appetizer is that the retropharyngeal lymph nodes are a paired group of lymph nodes. There's a medial and a lateral group, and the lateral groups are located just medial to the internal carotid artery. So here's our carotid artery, there's our jugular vein, and this would be the lateral pair of the retropharyngeal lymph node. And this is an example of a patient, and we see this occasionally, that's again a kid that comes in with a sore throat, has a fever. And anybody know what the exact diagnosis is here? So this is a lymph node that contains pus in it. And this is not technically an abscess. This is what's referred to as suppurative adenitis. So if you have a lymph node that essentially pusses out and contains pus within it, the proper term is suppurative adenitis and not a true retropharyngeal space abscess. But the way we can make this diagnosis now is that you look for this pus that's located off the midline and in the location of the retropharyngeal lymph nodes, and then you can make that diagnosis of suppurative adenitis. This, on the other hand, is a true retropharyngeal abscess. So we can see this fluid that's located in the retropharyngeal space. It crosses midline. And remember what I talked about earlier, right? The retropharyngeal space extends inferiorly into the chest and terminates between T2 and T6. So anytime that you have an abscess in the retropharyngeal space, we have to look at the mediastinum. And this is that same patient, and we can see here there's a severe mediastinitis and actually air in the mediastinitis that's due to this very aggressive retropharyngeal space abscess. Well, the next space is pretty easy too. And it's always funny. I always ask this question: how many of the residents have seen the pre-vertebral space in their practice? Right? Yeah, no one wants to say. And like, you know, I was, like I said, I was away last week, and none of the residents had seen the pre-vertebral space either. And then I said, no one sees spines, right? And everyone said, oh yeah, I see spines. So essentially, the pre-vertebral space is essentially the cervical spine. So when we look at the approach, when we take the fascial layers, this fascial layer right here, which is the deep layer of the deep cervical fascia, is the prevertebral fascia. Now, again, this has been renamed now. So if you read Amersis or StatDX, it's now called the perivertebral fascia. And this space is referred to as the perivertebral space. So again, two different names for the exact same location. So if we take our anatomically based approach to the prevertebral space, what constitutes the prevertebral space? Well, the majority of this is really formed by the vertebral bodies. So you have the vertebral bodies, you have the discs, you have the vertebral arteries. Now, right at the top of the head and neck, you do have the clivus. So the clivus is part of that prevertebral space. Part of the reason it was called the perivertebral space is because it also includes the perivertebral muscles. So again, the primary anatomic components of the prevertebral space, again, this was the original term, so that's why I use it, just to understand there's another term to identify the exact same location, really are the vertebral bodies, the discs, and the surrounding muscles. And those two primary paired muscles anteriorly are the longest colli muscles. So on the left-hand side is an example of discitis and osteomyelitis. We can see that infection has extended posteriorly into the spinal canal. And here we have an epidural abscess, and also associated with a retropharyngeal space abscess as well. Now, anybody want to take a guess what this is? This is a pretty, it's an aggressive infection, but there's relative preservation of the angle of the vertebral column. Anybody want to take a guess at this? This patient was from India. TB, exactly right. That's Pott's disease, exactly right. Now, this is one of those head and necky lesions. So if we take an anatomically based differential diagnosis, we think of the vertebral bodies, we think of the disc spaces, we think of the muscles. So the differential diagnoses are going to be things involved with the vertebral bodies. So we have discitises, we have osteomyelitis, we have metastases, myeloma, etc. Trauma. The disc spaces, like I mentioned before, the discitis, disc herniations, etc. Remember, it contains the vertebral artery, so we think of vertebral artery aneurysms or maybe a dissection. Again, all things that can occur anywhere else in the body, we're just mapping it to the head and neck. But there is one sort of head and necky lesion that we have to consider. And remember, at the top and the bottom, well, the vertebral column is formed by the notochord. And these types of lesions can occur either at the top of the notochord or the bottom of the notochord. They tend to be high signal on T2, solid on T1, and enhanced with contrast. And anybody want to take a guess at what this is, this tumor? Chordoma, exactly right. See, we know everything here, exactly right. Now, this is an example of a rare one, and again, I just show this not for the differential diagnosis, but the location. This actually is a neurofibroma that's involving the clivus. So the point here is there's a normal appearance of the clivus here on the right-hand side. Notice how all of the clivus is replaced on the left-hand side. In this case, it's actually surrounding the carotid artery, so this was just a pretty extensive neurofibroma within the prevertebral space. This was a vertebral artery dissection. A nice example here, non-contrast T1 weighted images. We can see the T1 shortening, the eccentric signal, resulting in narrowing of the vertebral artery. And here's the normal vertebral artery on the right-hand side. So there's that little pinching off of the vertebral artery. Again, in the diagnosis of a prevertebral space mass. So now the spaces get really hard, right? So now what do you call the space that contains the parotid gland, right? Yeah, it's a parotid space. It's really pretty simple. So I think part of the challenge of the spaces is that sometimes we get lost in the various names, and sometimes we just have to think back and say, what are we really trying to describe? And if you understand the anatomy, trying to what we describe, well, all of a sudden, the masticator space makes sense, right? We know there's a visceral fascia, so anything that we see when we look in someone's mouth, that's in the visceral space, right? The retropharyngeal space is that space located behind the pharynx. The pre-vertebral space is essentially just the vertebral column and the discs and the longus colli muscles, the surrounding muscles, so on and so forth. We see that every single day when we look at a spine. And similarly for the parotid space is what do you call the space that contains a parotid gland? And that pure and simply is the parotid space. Now we know the parotid space is there, and I'll just go ahead and contour the parotid space. Here it is, right there. And then when the surgeons do a parotidectomy, there's a special nerve that's associated with the parotid gland. And anybody want to take a guess what that nerve is? Yeah, it's the facial nerve, exactly right. The facial nerve. So on the right-hand side, this is a patient that underwent a superficial parotidectomy. Here's the main trunk of the facial nerve. And with the leap of faith, you can almost see the various branches here of the facial nerve. So what the facial nerve does, it separates out, it's in a plane, and it separates the superficial lobe of the parotid gland from the deep lobe of the parotid gland. Now, the facial nerve, we can't always see it on imaging, but there is a structure that gives us a pretty good approximation of where the facial nerve is located. And it's this vein right here, and this vein is behind the mandible. So what do you think you call this vein that's located behind the mandible? Retromandibular vein, exactly. Now that's a multisyllabic word that can be very confusing. But the reason we call it the retromandibular vein is because this vein is located right behind the mandible. So where is the facial nerve located? Well, the facial nerve is located just lateral to the retromandibular vein. So as a result, if that plane is continuous, that facial nerve divides a parotid gland into a superficial and a deep lobe. So when we start looking at lesions in the parotid space, it's important to understand exactly where the lesions are and whether or not they're in the superficial or the deep lobe. So let's go through a couple of differential diagnoses. So here's a patient that has multiple solid lesions involving the parotid gland. And these lesions that I'm referring to tend to be multiple, and they tend to occur in the tail of the parotid gland, and they're benign lesions. So anybody want to take a guess as what these lesions are? Start with a W. Warthin's tumors. So how do we differentiate Warthin's tumors from other lesions involving the parotid gland? So if I had to map out exactly how this works, I have parotid lesions here, and very simplistically, I separate it into benign and malignant lesions. Okay? So the benign lesions are Warthin's tumors, and its buddy, there we go, Warthin's tumor is a pleomorphic adenoma. So what are some things that I use to try to differentiate a Warthin's tumor from a pleomorphic adenoma? Well, Warthin's tumors tend to be multiple, and they tend to be bilateral, and they also involve the tail of the parotid gland. So why is that the case? Whereas pleomorphics tend to be solitary and sort of involve the mid portion of the parotid gland. Well, the other name for Warthin's tumor is what? It's called cystadenoma lymphomatosum. And Warthin's tumors are felt to arise or have some association with intraparotid lymph nodes. And intraparotid lymph nodes are located in four main areas. Anterior to your tragus, below the capsule of the parotid gland, along the facial nerve, and also in the tail of the parotid gland. So therefore, since Warthin's tumors are felt to have potentially some embryogenesis from the intraparotid lymph nodes, because we have multiple lymph nodes, because they're bilateral, because they're in the tail of the parotid gland, when we start seeing these lesions in the tail of the parotid gland, I certainly put Warthin's at the top of my list, and certainly if I see multiple, sometimes referred to as ear ring lesions, then I put Warthin's tumor at the top of my list, with the understanding that the patient does not have any other systemic malignancy. Now this, on the other hand, is something we used to see very commonly when I was a resident and a fellow. If I told you this patient was HIV positive, then what would the diagnosis be in this case and in this case? What's that? Anybody? Lymphoepithelial cyst, exactly right. Now some people say, why not Warthin's tumors? Because when you read the books, you'll say, well, Warthin's tumors tend to be cystic. Well, this is not the type of cystic or fluid in Warthin's tumors. They tend to be solid lesions with small little focal areas of low attenuation. These are big fluid sacs, almost like multiple glued together water balloons. And so therefore, this is more common with lymphoepithelial cyst. Now this patient was HIV positive. The triad for HIV positive in the head and neck is lymphoepithelial cysts, multiple enlarged lymph nodes, if you will, some of these shoddy lymph nodes, and a predominance of adenoidal tissue in the nasal pharynx. So that's the triad that's been associated with HIV in the neck. Now, this is an example of a patient that underwent a superficial parotidectomy and a total parotidectomy. So with a total parotidectomy, the surgeon has to dissect through the plane of the facial nerve and to try to get all this parotid tissue deep to this. So this is a much more aggressive surgery. So one of the things that we have to do as a radiologist is a surgeon may be able to feel that parotid space mass, but they may not fully understand the extent of the disease. Because like I showed in the prior study, the difference between this surgery, just a superficial parotidectomy, and this one, a total parotidectomy, is significantly different and associated with higher degrees of morbidity. So in this particular case, here's an early stage lesion. This was a small pleomorphic adenoma involving the superficial lobe of the parotid gland. We can say certainly with a high degree of confidence that it's localized to the superficial lobe. But in this particular case, notice that here's a pleomorphic adenoma that's involving the deep lobe of the parotid gland and extends deeply to involve the parapharyngeal space. So it's this information right here that really adds a lot of value. So one of the things people say with all this utilization that we're doing, especially in the head and neck, I would argue the reason we image so much is we offer so much, because this type of information directly affects the type of surgery the patient would undergo. And in this example here, a very aggressive lesion involving the right parotid gland. Remember the facial nerve. This was adenoid cystic carcinoma involving the parotid gland. And when we look at the contrast-enhanced T1 weighted image, we can see this enhancement right here along the descending portion of the facial nerve. This is retrograde perineural spread. And in this particular case, if the surgeon wishes to treat the patient with surgery, then the surgeon would have to drill out the descending portion of the facial nerve to chase this tumor. In general, the surgeon knows whether the tumor is benign or malignant, because if the facial nerve is not working, he or she would know, have to make sure it's he or she, otherwise my wife, my daughter will kill me. They would know that it's a malignancy, but really our job is to really define the extent of the disease. Well, I'll briefly mention the parapharyngeal space, because as I mentioned, Dr. Sam will talk about that later in great detail. But the parapharyngeal space, pretty simply, is a space adjacent to the pharynx. So here's our visceral fascia here. There's our parapharyngeal space just lateral to the visceral fascia deep to it. Now, there are different names to this. So in the radiology lexicon, we use the term of the space anterior to the styloid process as the parapharyngeal space. And as we'll see later, the space back here that contains the carotid artery and the jugular vein behind the styloid process, we refer to this as the carotid space. The ENT surgeons will refer to this as the pre-styloid parapharyngeal space, and the space posterior to the styloid process as the post-styloid parapharyngeal space. So again, as I mentioned before, it's the same piece of anatomy, we just give it different names. So the most common tumor to extend in the parapharyngeal space is deep extension of a tonsillar carcinoma in the parapharyngeal space. The most common tumor that I've seen to arise within the parapharyngeal space is actually a minor salivary gland tumor, with that being a pleomorphic adenoma. And this is just an example of a tumor, again, involving the parapharyngeal space. If I'm not sure, all I do, again, stick my index finger in the middle of it, map it to the opposite side, and I can say it's in the parapharyngeal space. And here we can see the fluid level, if you will, and this just happens to be a lymphatic malformation. So that's all I'll say about the parapharyngeal space, and I'll leave the rest to Dr. Sam. The post-styloid parapharyngeal space, as I mentioned, is also known as the carotid artery. And the carotid artery, the carotid space contains the carotid artery, the jugular vein, cranial nerves 9 through 12, and the lymph nodes. And again, all of these components in the carotid space, we've seen before, they're everywhere else in the body. So if you just remember there's an artery and a vein, some nerves and lymph nodes, you've come up with a differential diagnosis. It's really that simple. So for instance, here's a large vascular mass involving the carotid space. The carotid artery is focally dilated, and this is what? Anybody just sing it out real quick? So what? Anyway? Aneurysm, right? This patient had a central vein line, and we can see there's no enhancement at all involving the jugular vein. So this is, anybody want to take a guess what this is? Yeah, jugular vein thrombosis, right? And here's a patient that underwent trauma. We can see the eccentric area of increased T1 signal. Look what's happening to the carotid artery. It's narrowed here on the left compared to the right. Here's our gradient echo sequence, and we can see it's narrowed. So this is just a simple dissection involving the carotid space. Now, both of these patients have lesions involving the carotid space. One of the key things here is the indicator of the carotid artery. So what I like to see is when I look at something like this, what I like to find as the carotid artery. And if I see that the carotid artery is being displaced posteriorly, then that tells you the mass is probably in the parapharyngeal space. If the carotid artery is displaced medially, then that tells me the mass is probably arising from the parotid space. If the carotid artery is displaced laterally, then that suggests that the mass may be arising from the retropharyngeal space or the pre-vertebral space. And if the carotid artery is displaced anteriorly, then that tells me it's probably arising from the carotid space. So what do I do then? And I draw my line down the middle, and I compare one side to the other side. And now I see the carotid artery is displaced which way? Anteriorly, exactly right. So that tells me it's in the carotid space. So the next thing that I have to determine is once I know it's in the carotid space, I start looking internally. And I start looking for what? I start looking for these black things right here, which are what? Flow voids, exactly right. So in the case on the left, there are no flow voids, but the lesion's in the carotid space. So the most likely diagnosis is going to be schwannoma or a neurofibroma. On the other hand, in this case, we can see multiple internal flow voids, and therefore it tells me it's probably a glomus tumor. Now, granted, the flow voids is not 100%, but in general, if a lesion is greater than 2 to 2.5 centimeters, I would say that the majority of glomus tumors, you will see the flow voids, and the absence of the flow voids in these lesions that are, again, greater than 2 to 2.5 centimeters, it's a pretty strong indicator that you're dealing with a non-glomus tumor and most likely a schwannoma. Another example here, a schwannoma, we can see anterior displacement of the carotid artery, no flow voids on the non-contrast T1 weighted image. There's our T2 weighted images, has a little bit of increased signal. And when we did the MRA study, we can see there's no flow voids within it. Now, certainly, MRA is not as sensitive for angiography, but for a good screening tool, the MRA is a pretty good way to, and a first pass, if you are worried about a schwannoma versus a glomus tumor, it is a pretty good way to look at it. Certainly, if you have time-resolved angiography, tricks, tracks, or treats, or whatever vendor you're using, again, those are true. It's a tricks, tracks, or treats. It's a pretty good way to look at the vascularity within the carotid space masses. Another example here, a hypervascular lesion involving the carotid space, contrast-enhanced T1 weighted image, again, very nicely demonstrating the internal flow voids, in this case, of a glomus vagale tumor. So this carotid space tumor is separating the internal and the external carotid artery. We can see there is a carotid body. So if you have separation of the internal and external carotid arteries, think of carotid body tumors, and this is that tumor after embolization. If the internal and the external carotid arteries are pinched together, then we have to think of a glomus vagale tumor, and these arise from what's referred to as the nodose ganglion. Pre-embolization, post-embolization, in this case a very nice embolization, but it also nicely demonstrates how the external carotid artery is pinched towards the internal carotid artery. Another example here, densely enhancing mass on CT. There's the lesion again right there, again very nicely demonstrating the flow voids. And if your glomus tumor arises from the jugular foramen, from the superior cervical ganglion, this is what we refer to as a glomus jugulare tumor, and I'll have more to say about that in the temporal bone talk. Now, this is a disease entity. It's more common than initially thought. A surrounding soft tissue mass that encases the carotid artery. The patients oftentimes have pain in the neck, and there's no history of lymphoma, squamous cell carcinoma, or anything. The pain's relieved with aspirin. Anybody want to take a guess at what that diagnosis is? It starts with a C. Carodinia, exactly right. The last two spaces that we'll talk about, again, are pretty simple if we understand a little bit about the classics, right? Anybody take Greek or Latin in college? One person. All right, good. All right, good. So what's Greek for tongue? What's that? No, that's Latin for tongue. Glossus, exactly right. And what's Latin for tongue? Latin for tongue is lingua. Greek for tongue is glossus. And again, like I said before, we take the same piece of anatomy and we give different names. And it's even harder when we talk about these spaces because we actually change the roots to signify the same area. So if I talk about the space that's below the tongue, then I'm thinking of the sublingual space. So when I think of the sublingual space, it's essentially the space that's below the tongue. Now, again, if you look at my contorted way of thinking, the sublingual space is technically below the tongue. Now, having said that, what do you call the name of the muscle that goes from the hyoid bone to the tongue? And think Greek root now. That's a hyoglossus muscle. Exactly right. So you see how we're flipping the roots for this space. So the sublingual space is below the tongue. The rim, or the direct lateral margin, is formed by the mandible. This area right here, this muscle right here, is the mylohyoid muscle, and the base of the mylohyoid muscle is formed by the hyoid bone. So again, anatomically, the sublingual space is down here. Here's the mylohyoid muscle. Here's the mandible. Here's the hyoid bone. So again, if you take the same drugs I do, you should try it with sometime. That's a joke, all right? It almost looks like a teacup. So essentially, for me, everything within the teacup is in the sublingual space. So the rim of the teacup is formed by the mandible. The wall of the teacup is formed by the mylohyoid muscle, and the base of the teacup is formed by the hyoid bone. So can everyone sort of conceptualize my little teacup here? So essentially, everything within the teacup is within the sublingual space. So what are some pathologies that we see in the sublingual space? Well, the most common tumor to involve the sublingual space is squamous cell carcinoma, as is seen here, T1 weighted image with contrast with fat suppression. Another pathology that we have to be concerned about is if a patient does come in with a fever. This is a sublingual space abscess, and when we look at the bone here, we can see this sclerosis. And this was, in this case, we can see, in fact, a rotten tooth. You see the root of this molar here? There's the little lucency surrounding it. That is a sublingual space abscess. When we talk about cystic lesions, and we'll have much more to say about this later, a cystic lesion involving the anterior floor of the mouth that's midline. This is, anybody want to take a guess? Starts with an E? Anybody? Epidermoid? What about this cyst that's located perimidline? Think frog. Exactly, a ranula. Now, ranulas can be above the mylohyoid muscle, in which case they are called simple. But on the other hand, if the ranula extends inferiorly below the mylohyoid muscle, again, we'll talk about this later, it has three different names to it. Again, the same pathophysiology, but it has three names. So if it extends below the mylohyoid muscle, it's called a plunging, diving, or a complex. So again, the same pathophysiology, for some reason we've just given it different names over time, just to confuse you. Anyway, the last space that we'll refer to again is very simple. What do you call the space that's below the mandible? And the space that's located below the mandible is pure and simply the submandibular space. So here's our mandible, here's our mylohyoid muscle, so the space inferiorly to the mandible and the mylohyoid muscle is in the submandibular space. And there are a few things in the submandibular space. One of the largest components of the submandibular space are the level 1 lymph nodes. And the level 1 lymph nodes are also known as the submandibular lymph nodes, obviously. There's also a gland located in the submandibular space. You all know that. That's the submandibular gland. So one of the common things that you'll see in your general practice, if you are in a general practice, you'll see these little sialoliths. So remember, the duct of the submandibular gland is Warthin's duct. And Warthin's duct crosses over the free margin of the mylohyoid muscle and then has this course within the sublingual space. So when you are looking at CT scans and you see this little calcific pebble here involving the sublingual space, you have to take a close look back at the submandibular gland to see if, in fact, this is an obstructive sialadenitis that's obstructing the Warthin's duct. And this is one example here, the same case. you can see we have obstruction of the left submandibular gland. There's our obstructive sialadenitis. Now, you know from the previous case that Wharton's duct runs within the sublingual space. So now we have to take a really, really close look in the sublingual space to see if we can see the etiology that's causing obstruction of the submandibular gland. So we know it's got to be in the floor of the mouth, and we're looking for something subtle. So anybody see anything at level A, level B, or level C? So can I convince you here? You see the fat plane normally here in the anterior floor mouth here? See that right there? Can I convince you that flat plane is absent right here? Right? Anybody buy it? Right? So there it is. This is a subtle squamous cell carcinoma that's involving the floor of the mouth. And granted, it can be subtle like this, but what increases your sensitivity? What triggers your radar to have a really close look at this? And what's triggering your radar is this obstructive sialadenitis, knowing full well that Wharton's duct is coursing along the sublingual space because eventually it enters into the frenulum, right below, just behind your front two teeth. And that tells you you have to look very closely. So when you see something like this, it's going to increase your level of confidence that there indeed is pathology there. And this is just an example of a ranula. This was a ranula involving the sublingual space. And this is that inferior extension into the submandibular space. Again, the name's to a diving, plunging, or complex. And the reason why it's important, because if the ranula is located purely intraorally, a simple ranula, they can be marsupialized by the surgeon in a nice intraoral approach. But if indeed the ranula extends through the mylohyoid muscle, then the surgeons typically have to also perform a cervical approach in order to completely resect that ranula. So in summary, what I've tried to do over the last 45 minutes or so is talk about the various spaces. We talked about the masticator, visceral, retropharyngeal, pre-vertebral, parotid. So thank you very much for your attention.